Thank you, madam. This is just a small surgery, two surgery series on some new tricks in foreign body removal. So this is the first case was a 8-year-old boy who came to us with a secondary infection following bone arrow injury. He had a severe vision loss with inflammation in the anterior segment as well as vitreous exudates. The whole vitreous cavity is filled with the severe vitritis and vitreous exudates, and otherwise normal. He had an initial corneoscleral tear repair just next to the limbus, and in spite of the surgery, he was deteriorating, and that's why he was referred to a hospital. So the ultrasound showed some small high intensity echoes because we are cut as a. It's not very clear what sort of foreign body it was, but from the history, we are not very sure whether what went inside because the stick, because we were not able to identify the exact length of the stick from the ultrasound. So this is how the foreign body is located. It was where the superficial star was sutured. The long piece of foreign body is sticking from the limbus where the injury had happened and was hitting the retina just nasal to the disc. You can see the choroidectomy in process. There's significant vitreous exudates, and you can see that now there's a stick there. It is sort of incrusted between the anteriorly from the sclera posteriorly onto the retina. That's the site of entry where the suturing was done earlier. So it's a long and non-magnetic foreign body. That's the main issue here. So you can sort of sorry. So that is the foreign body there, and you can see now it is just I am just lifted it from the retinal incarceration here and freed it from the posterior adhesion. It is still anchored to the anterior scleral area. So I'm trying to access it from the opposite side of entry. So you're making a large sclerotomy there to avoid using the same entry point, because it's not easy to remove to the same entry point because it's already sutured. So to prevent it from falling down and causing further retinal injury, because already the nasal retina is injured. So what I am trying to do here is doing a fluid exchange and injecting oil into the vitreous cavity. So my logic is that oil will be more viscous and it will keep the foreign body in place even if my forceps slips off. Because this is the Machimer two-prong forceps here, foreign body forceps, because it's a large foreign body. Routine forceps do not work well. And that is the forceps in place now. So I'm holding the stick and trying to remove it, but you can see that it slips off. But even if it slips off, you can see that foreign body is not falling down. The reason being that the high viscosity of the silicone oil which is inside. So here I'm using silicone oil as an adjunct to prevent retinal injury in case the foreign body falls, especially in a non-magnetic foreign body. So I'm trying to go inside again and grasp the foreign body with the same forceps. And now this is the foreign which is coming out right now. I'm trying to extend the sclerotomy a little bit to prevent repeat falling of the foreign body. And using the cyclospatula to sort of mobilize the foreign body for easy exit. So that's the first case where we removed a long stick from the intravitreal space. So second case is a 21-year-old male who had a history of, he was drunk at that time, so he was not sure how he really got injured. So he came with a secondary infection and panophthalmitis, in fact, and no pale vision. And the CT revealed a large foreign body was seen in the vitreous cavity. And it was totally panophthalmitis with severe orbital edema, proptosis and everything. He was not responding to routine therapy with the intravenous antibiotics, intravitreal antibiotics. So finally decided to go on, even though the media was very hazy, we thought we'll make a try to go and remove this. So this is after removed all the superficial exudates, there was a lot of bleeding inside, put in air. Then only I was able to identify it was actually a short air gun pellet, which was used for, I don't know how he got injured. He was not really aware how he really got injured because he was drunk at that period of time. And you can see the very heavy foreign body with a lot of bleeding and significant exudation in the vitreous cavity. So the same technique we are using here. After I'm just putting in oil to fill up the vitreous cavity. Now this is the Bapai claw forceps. I'm using the Bapai claw forceps, and the oil was keeping the blood from mingling into the vitreous cavity and causing loss of clarity, vision. And you can see that now I have grasped the air gun pellet, and I'm trying to remove it through the superficial scleral tunnel here. So this you can see now it is coming out. Using the McPherson forceps, I'm grasping the air gun pellet and removing it through the So advantage of putting oil in these cases, it prevents bleeding mixing into the, if you have a BSS going in, it immediately causes visibility loss. And also when you make such a large exit wound for the removal of a large foreign body, the eye collapses, causing difficulty in visualization and also increase in bleeding. So oil helps to keep the media clear, keeps the globe stable and intact for easy access and removal of the foreign body. So we have a lot of other forceps for removing of non-magnetic foreign bodies, and people have used even the ENT crocodile forceps for removal. And we have the basket forceps. We have the this is the Machimer claw forceps. You can see it in how it is used to remove this. Okay, it's not playing anyway. So this is the Bapai claw forceps, which is a new addition to our armamentarium. This is the Bapai. One of the disadvantages of Bapai is that when you close, the prongs retract, so you have to compensately move your forceps forward to grasp the foreign body. Is one of the negative side effects of using the Bapai claw forceps. Anyway, apart from this, just showing that this is a case of a pencil nib, large pencil nib in the vitreous cavity. Two kids were fighting at school, and one of them stabbed the eye with his pencil, and the pencil got broke. You can see how it's very difficult to remove these smooth foreign bodies, especially non-magnetic foreign bodies. It tends to keeping on falling. I almost dropped this 8 times before I was able to remove it. Luckily, there was no injury to the retina. So oil helps to prevent all these bad things from happening. So oil can be used as an adjunct to prevent both retinal injury, maintain the globe intactness, as well as keep the media clear when removing non-magnetic foreign bodies. And it's a very helpful adjunct. Unlike PFCL, it has got a little bit more viscosity. So you can see that this is a foreign body being dropped in silicone oil and vitreous routine BSS. PFCL is a little bit higher viscous than in between both saline and silicone oil. So oil gives you much more better viscosity to keep the globe intact. And that's one thing which you have to keep in mind when you're dealing with the large non-magnetic foreign bodies. Thank you.
Thank you, Dr. Saravanan. That was an excellent presentation. For the benefit of the crowd, I would like to direct one question to you, that what would be the size of the object which you would think of either taking it out from the scleral root, or you would prefer to remove it from the limbus?
So any large foreign body which is, irrespective of size, you have to look at the ease at which you can grasp and remove it. If you're going to foresee frequent slippage and falling down, every time it falls down, picking it up from the retina is going to cause more injury. Wherever you expect that you're going to have a tough time removing it, even irrespective of size, that's smooth. Like there was a pencil nib, was quite a small foreign, but it was very smooth. It was slipping off. In all those cases, better to remove through the anterior route, handshake technique, rather than trying to remove the sclerotomy. Sclerotomy has got a much higher risk of slippage than the limbal route.
Another question which I had to you regarding foreign bodies, that if you have a glass foreign body in the eye which is not creating a problem within the eye, it's just lying in one corner, it's not causing any kind of problems over there, would you remove it or wouldn't you remove it?
So inert foreign bodies like glass, diamond, gold can be left inside, especially if you fear, especially in eyes with a very good visual potential. Because if you feel that it is not going to cause issues, better to leave it inside, especially in eyes with good visual potential.
Dr. Naresh, over to you. Can I ask him anything?
Especially, but law says that you have to remove all foreign bodies. That's one's negative side of leaving it inside. But in case you retain foreign bodies, 6 monthly vision and ERG to look for any toxicity. Toxicity is a must. But as per law, we are supposed to remove all intraocular foreign bodies. This is the other side of the coin.
No, in case of a glass, do you really need to remove it, or you can hide it somewhere and leave? Because it's going to be inert, and the collateral damage we get while removing a glass foreign body
is much more higher.
Yeah. So should we remove it, or we should?
That's what I was saying. If it's visual is in a good visual potential eye, I would prefer to leave it inside. That's what I was saying.
Okay, actually, we do the surgery to give prognosis. In this case, to give a good visual prognosis, you don't remove it.
Yes.
So in a patient with no perception of light, with trauma and a young boy with vitreous hemorrhage and all, would you do a VEP and still give them, the...
So in a severe trauma with no PL, people can still regain. There are a lot of case series where people have regained significant vision. And VEP is not a very good tool to assess visual potential in these sizes. You can give you some information, but it's not like a cutoff where if it's a VEP is poor, you don't do it. Because in VV, no PL eyes, especially in severe trauma, are not a contraindication for advising no intervention. So that is not a contraindication. It's actually, we have to try to, if the patient is willing to go for surgery, always go in for surgery. Don't keep no PL as a contraindication for surgery.
You showed us a wooden foreign body, which you removed very effectively and nicely. In that eye, he didn't have any kind of major signs of endophthalmitis. But if you do remove a vegetative foreign body, would you put them on some antifungals in the post-op period?
Especially in vegetative bladder, it's always better to put them on antifungals, both topical and oral, for a short period of time to see and if it's infection is resolving very fast, you can stop the medication later on rather than waiting to see if it's getting worse and then starting. Better to start it in the first stand itself.
Sir, what difficulty you find while removing this kind of a silicone oil? Like when the PVD is not complete, already the view may be
No, this is just an adjunct. We don't keep the oil. We removed immediately. The second case, I removed the oil after removing the foreign body.
Okay, so do you find any difficulty in that, or just by the active section you?
No, because they got a large wound. Once you switch on the infusion, the oil will come up in 10 seconds. It will come out actually.
Ideal oil, 5,000 or 1,000?
I don't see much of a difference between 1,000 and 5,000. To aid the easy injection and removal, I usually use 1,000, but you can go for 5,000 if you feel it is. But it's not a much big difference in viscosity.
So you were using a simple forceps, but you have these.
Sir, one question.
Go closer to the mic.
Is there any iron particle have entered in the eyeball, and you know that the iron, but the visual potential eye, you have told that it is to be wise to wait for until unless the ERG shows toxicity. Sir, it is always unfavorable the follow-up of the patients in our government sector. Those patients are staying in rural villages, whether they will come back again always. In that situation, what the ophthalmologist will do like us?
Sir, we're talking about inert foreign bodies like glass, diamond, gold. In those cases, you can sort of safely leave. Even in those cases, you'll have to do 6 monthly follow-up with the vision and ERG to check toxicity. But iron, because it's magnetic, you've got a lot of good magnets there. You can easily, safely remove iron foreign bodies much more easily. And iron, if you leave inside, the risk of siderosis is considerably high. So iron foreign bodies, do not leave it inside the vitreous cavity. I was talking about inert, madam was asking about inert foreign bodies.
So I was asking about this simple forceps that you were using to remove the pencil thing. But do you think that the tip of the pencil with a 3-prong forceps would have been better to kind of come out?
We don't have, recently with the Bapai forceps is large enough to hold, but the previous generation of claw forceps was very small. It's not fit enough to hold the large. This is actually, this is not a routine pencil nib. It is that this foreign make of pencil where they have this attached to a plastic hub. So the size of the pencil nib is quite large, unlike routine pencils. So it was very difficult to hold it.
Wilson's forceps, they had the small
So I didn't have the
prongs.
Bapai at that time of when I was doing this particular surgery actually.